One of the things that I do want to go over with you guys is blood and blood products administration. As you may know, one of the things that we don't let you do in school is administration of blood products. Two reasons. Number one, yeah, that's number one, because the risk of a reaction is very high. Think of blood as actually a transplant, because it actually is a transplant of cells from someone else into someone's body. Second thing is, of course, a lot of hospitals will prohibit students from doing that. It has to be licensed personnel, and the majority of the times with most hospitals it requires 2 RNs, or if you look at CMC Northeast policy, it's 2 licensed people. One can be an LPN, but the RN has to be the one that's actually administering the blood. Now, one of the things that happens is that you magically pass NCLEX, magic, okay? And you know all about blood administration because now you have a license. Well, no you don't, okay? The other reason that I want to go over this is there is a fairly decent section in the NCLEX test plan that talks about blood administration, not only how, but why, and what kind of complications can occur and how you deal with those. So this is your blood administration. Doesn't mean that as a student you're going to be able to do any of this, but I do want you to have the theory behind it because you will be tested on NCLEX about it, and yes, you will be tested on the test on Thursday about it. This is material that you're going to be tested on. Not this first part, because the history I like. So you've got to sort of trudge through it. Remember in the early 1600s, William Harvey was the one that discovered the circulation of blood. And the first known blood transfusion was attempted soon afterwards. More than likely, the patient died. Basically, the first successful blood transfusion did not occur until 1665. And it wasn't even in a human. It was in a dog at that point. Basically, you sort of go along until the 1800s. When you found that in 1818 an obstetrician had the first successful transfusion of human blood to a patient, and that was for postpartum hemorrhage. After that, they were trying all sorts of things. Milk from cows, goats, and sheep. Even human breast milk, they were doing transfusions. And of course, more than likely, those patients died of overwhelming infection and sepsis because of that. Basically, what happened in the early 1900s, we had the discovery of human blood groups. So that we now knew that there had to be some type of matching of those blood groups to make sure that we have a better chance of having a transfusion, less chance of having a transfusion reaction. 1914, what we're talking about, long-term anticoagulants, so does sodium citrate, are developed, and that would allow for blood to last a lot longer. Sodium citrate is still used as a preservative of blood today. In 1940, basically the RH blood groups were discovered, and basically what we found is that people that are either RH negative or RH positive, and you don't want to mix those. Remember we talked about the problems that you get with an RH positive baby and an RH negative mom, where if there's bleeding, either placental bleeding or separation with birth, that mom that's RH negative becomes immunized against those RH positive antibodies, and the next baby is going to have erythroblastoma, whatever, okay? Meaning that there can be major damage to that child. Now, what happened in 1941, Dr. Charles Drew basically he was an African-American physician, researcher, and surgeon. Basically is called the father of the modern blood bank. Basically, he developed a method that allowed for blood storage for transfusions that saved many thousands of lives in World War II. Basically, he developed the method that storing blood plasma that allowed it to be sort of freeze-dried. And so that what happened is they were able to do blood drives, dehydrate that blood, and then in the combat fields, rehydrate it and transfuse it into the soldiers. Basically, what you will see is that Dr. Drew is, as they say, the father of the modern blood bank. It really is unfortunate that he died as a result of an automobile accident in Greensboro. Contrary to popular belief, he did not die because he was refused blood because he was African American. He died because he had a complete sever of his femoral artery, and he bled out. 1944 to present, basically what you will see is that ABO blood typing and syphilis testing were performed starting in 1947. Of course, syphilis testing was recommended because of all the soldiers coming back from World War II. It was not until 1971 when hepatitis B surface antigen was tested. So people that received blood before 1971 did run the risk of getting hepatitis B. People that got blood from donors before 1992 basically ran the risk of developing HIV because it was not really tested for HIV until 1992. And then in 2002, that's whenever we started testing for hepatitis C. So what you're going to see is that until really the 2000s, blood transfusions, you ran a risk of getting it, as well as it could be life-saving. Now, a couple of things. Let's go through some of the blood components. Stem cells. Probably this is one of the things that you're going to see more and more and more about in the next 2 decades or more. Basically, stem cells are unspecialized cells that renew themselves through long periods of time, and basically they can be induced to become specialized cells. I mean, like he was talking about the artificial skin, or the skin gun yesterday. Those were stem cells that were induced to be skin, okay? They have started to do stem cells. I know that Wake Forest grew an ear on the back of a mouse a couple of years ago for transplant. The stem cells basically have replaced bone marrow transplant for patients that have had massive chemotherapy for like breast cancer or leukemias. They used to do bone marrow aspirations and infused the bone marrow. Now they're doing stem cell transplants. So I would say that stem cell is probably going to be one of the things that you're going to see more and more. They are right now doing research on people that have had massive MIs, transfusing them with stem cells, and what is showing promising results of that heart muscle regenerating itself, so that hopefully heart failure will be a thing of the past. The other thing that they're doing is that they are developing stem cells so that they're like insulin-producing cells for the pancreas. And what we're hoping is that type 1 diabetes may be able to be cured in some future time. Okay? But stem cells are probably going to be something that you're going to see more and more of as we progress through. Now, with blood components, you know, plasma is the liquid portion of the cell. Of the blood, it's the extracellular fluid, water, albumin, globulins, and fibrinogen. About 55% of the blood is actually plasma. Okay, remember what we said about albumin, that what it does is it affects that osmotic pressure of the blood and holds that fluid in the intravascular space. Serum, when you're talking about serum, that's plasma minus the clotting factors. Now, blood cells themselves, erythrocytes, leukocytes, and platelets. With erythrocytes, the largest portion is those red blood cells. They have a very flexible membrane, and they last about 120 days for their lifespan. Okay, now that 120 days is if they have been produced by that person's body. If you take blood cells and transfuse them into someone else, the lifespan of that red blood cell is still from the time that it was sort of developed or issued or birthed, so to speak. So what you usually find is that red blood cells from transfusions don't last that 120 days because they're already mature cells at the time that they're transfused. Heme and globulin are part of the hemoglobin molecule. Heme is the part that's the iron. The globulin carries the oxygen. Basically, got that backwards. Heme is the iron and carries that oxygen. Globulin actually carries carbon dioxide back to the lungs to be diffused off. Basically, what you're going to see is that the erythropoiesis causes production of red blood cells. Okay? How do we get erythropoiesis? How does that occur? From the kidney. From the kidney, okay? So if you have poor blood flow to the kidney, what's that going to do to your production of red blood cells? It's going to decrease it. That's why your people with acute renal failure or chronic renal failure are typically already anemic. Okay? Okay, Procrit or Epigen, okay, are medications that you can give to induce erythropoiesis. Thank you very much. With leukocytes, those are your white blood cells. Remember, they basically talk about inflammation and antibody and cell-mediated immunity. With inflammation, you're talking neutrophils, macrophages, monocytes. Basically, what you're going to see is neutrophils are at the site of infection and increase in acute phases. so what you're going to see is that whenever you have someone that is leukocyte poor or neutropenic, then they're going to have a increased risk for infection. A lot of your cancer patients, especially those that are getting chemotherapy or radiation therapy, have problems with neutropenia. Beta cells, basically, what they do is they release histamine in an allergic response. And sometimes histamine is not a good thing because that can cause problems with airway management. Okay? T cells, those are your immunity, and HIV commonly targets those T cells. Platelets or thrombocytes. Really what platelets do is they are little plugs. What they use is that these are used as plugs. See, these are the fibrin strands, okay? And what the fibrin does is it catches those platelets, and that's what forms that clot. Production of your platelets is controlled by thrombopoietin. Platelets, as a general rule, have a lifespan of 1 to 2 weeks. Now, as we said earlier today, the spleen destroys all of those red blood cells, stores the platelets until they're ready to be used, and then it also filters antigens. So if you have someone that has a large amount of infection, typically they're going to have a splenomegaly. Okay? Again, your liver, the blood clotting factors, it stores blood and blood cells. And it does produce a very minimal amount of erythropoietin, but it typically is not enough to combat the anemia when you have someone with acute renal failure. Now, hemostasis and blood clotting, Lord help you, Jesus. This is what the cascade looks like. Remember this, blood clots until it doesn't. Okay? So that's basically what you need to worry about. Now, what you will find is that what acts on 10A? What medication? Heparin. Okay? Basically, factor 7 and factor 8. Okay? Basically, you're talking about people that have problems with like hemophilia. Okay? Just don't worry about intrinsic factor, extrinsic factor, fibrinolytic network, blood clots until it doesn't. Alright. So, some of the changes that we see with aging. Overall, we have a decreased blood volume. Part of that is due to decreased total body water. Little old folks tend to be dehydrated. You will have lower plasma protein levels. Why do these people, as they age, develop lower plasma protein levels? Nutrition. They don't eat as well as they should. The other thing you see with aging is that our bone marrow does not work as well. Okay? It produces fewer cells. The lymphocytes, or the white blood cells that we do produce, are less reactive to antigens. And so, therefore, we don't see as high a rise in white blood cell level in response to infection. Our hemoglobin levels fall. Part of that is also nutrition. Now, these are three that you need to think about. DIC, I know Ms. Rommel has already covered, and we'll go over hemophilia just a little bit. Basically, HIT, ITP, and TTP are something that you sort of need to know a little bit about. HIT syndrome or heparin-induced thrombocytopenia. What is a thrombocytopenia? Decreased platelets, okay? Basically, HIT is an autoimmune disease, and it usually is triggered by the presence of heparin. Heparin-induced, okay? Basically, what you will see is that about 3 to 5% of people that receive low weight heparin, like your Lovenox or your Rixtra, those low molecular weight heparins will develop HIT syndrome as well. Okay? So what you will see is that there's an unexplained drop in the platelet count following heparin therapy. Well, the reason that we are giving these people either heparin or low molecular weight heparin is to prevent what? Clots, and specifically DVT, right? Okay? What you see with this patient, if they develop HIT syndrome, is that unexplained drop in platelet count. By definition, it's drop by 50%. So if I have someone that comes in to the hospital with a 400 platelet count, okay, normal platelets are what, guys? 150 to 400, okay? They come into the hospital, I give them 2 days of heparin, and then I notice that their platelet count now is 200. That's a 50% drop, okay? Even though 200 is still within that normal range, right? Would I be concerned? Yes. Okay? If there is a drop by 50%, it's something that you need to make that healthcare provider aware of. Typically, it occurs after 5 to 14 days, though I have seen people that have had it previously that has not been recognized will show symptoms after 1 or 2 days. Because it's sort of like an allergic reaction. If you develop it once, the next time I get heparin again, I'm going to have an immediate reaction to it. Okay? So what you're going to worry about is that these people are going to have problems with low platelets. HIT syndrome. If they develop HIT, discontinue the heparin or the low molecular weight, the Rixtra or the Lovenox. Typically what you will see them use are these, bilirubin or lepirudin or agraban. Okay? These are direct thrombin inhibitors. Typically when you see these meds used, they're used after a cardiac cath to keep that stent open, but you're giving them in much higher doses than you would be to prevent DVT. Okay? Typically what you're going to see with people with HIT syndrome is that 38 to 52% develop DVT, PE, stroke, or MI within 1 month. Okay? And what? They should always be told, you're allergic to heparin. You should never take it again. Okay? Because every time that they get heparin after the development of this, then they increase their risk of DVT, PE, or stroke. Okay? So HIT syndrome, think of it as heparin allergy. Major symptom is decrease of that platelet count by at least 50%.
When you discontinue it, would you give her something?
No, just discontinue it. Heparin, the half-life of heparin is so short, okay? If it's given IV, the half-life is less than an hour. Okay, if it's given sub-Q, typically it only lasts 6 to 12 hours. So usually what you'll see is that you don't have to give anything to counteract that disease. Now, what may happen is it depends on how low their platelet count drops. You may be given them platelets. Okay. But you're definitely going to be observing them for risks of DVT, PE, or stroke. Now, autoimmune thrombocytopenic purpura. That's why they call it ITP. All right, ITP basically is a severe reduction in circulating platelets. We're talking about, instead of the 150 to 400, we may have people with ITP that have 20,000, 30,000, 15,000 platelets. Okay, so that it's a very, very small amount. Typically, you'll see it in your patients that have other autoimmune diseases like lupus or some other things. What happens with these patients clinically, you see large bruises, mucosal bleeding, and severe anemia. Treatment usually is some type of drug to suppress the immune function. Corticosteroids usually are the drug of choice. And then blood transfusion with like platelets. But what usually occurs is that the same process that destroyed the platelets that they normally made destroys the platelets that are transfused. So it doesn't work very long. Okay, you can't just keep giving them platelets because those get destroyed too. Now, what happens is that if you have someone that's getting major problems with this, they may do a splenectomy. Because removing the spleen basically will decrease the destruction of those platelets. But if I take someone's spleen out, what implications is that going to have for me as a nurse?
Infection.
What about infection? They're at increased risk for infection because remember the spleen is that first line of defense. So someone that has had a complete splenectomy or partial splenectomy is at greater risk for infection and sepsis for the rest of their life. Okay, TTP, thrombotic thrombocytopenic purpura. Basically what happens to these folks is they have inappropriate platelet clumping. They just sort of clot everywhere. Again, it's an autoimmune reaction. Typically what you see is bleeding, renal failure, MI, and stroke because of those inappropriate clots. Typically what you're going to see with these folks is plasmapheresis, FFP or pressure frozen plasma, and they're going to get platelet inhibitors. Okay, so what basically meds are we going to see used as platelet inhibitors? Plavix, aspirin, Untitled is another one that they use sometimes. Okay, but those are meds that you're going to see used with TTP. All right, DIC. They bleed, they clot. They bleed, they clot. They bleed, they clot. Okay, remember this is one of those CTD, circling the drain type of diagnoses. It's an abnormal response. Typically what you're going to see is that they will use all their clotting factors up and then they bleed. It freaks people out that these people are bleeding from every orifice, but what you're giving them is heparin and clotting factors. It sometimes makes no sense because they're bleeding, you give them heparin. Well, the heparin is to keep them from clotting and using all those factors. Okay? Alright, hemophilia is an inherited X-linked recessive trait. There are two types, hemophilia A, which is a deficiency of factor 8. Hemophilia B is a deficiency of factor 9. Typically what you will see with patients that have hemophilia, it's abnormal bleeding from any trauma. Typically prolonged PTT. Bleeding time is normal. PT is usually normal. Typically what you will see is that they will give them cryoprecipitate with one of these clotting factors in it. And typically what you will see is that this cryoprecipitate is administered on a routine basis by a family member or the person that has the hemophilia. Okay? It basically, typically what you see is it's sex-linked on that X. Usually what you will see is that female children will be carriers, but males will have the hemophilia. Okay? Which is sort of fortunate because if that female was to be hemophiliac, once they started menses, what would happen? They'd bleed to death. Probably the biggest family with hemophilia in it was the Tsars in Russia, and they got it from Queen Victoria of England. Just FYI. Transfusion therapy. Basically, when we talk about transfusions with red blood cells, these are the new guidelines. Basically, what you're going to see is that they do not recommend that ICU patients, either adult or pediatrics, have a transfusion unless their hemoglobin is less than 7. Okay? Post-operative, they want to see less than 8, or if they're having symptoms. What symptoms would you imagine that they'd want to see? Fatigue. Mental status changes due to what? Hypoxia. Okay? That's basically what you want to see. Again, cardiovascular disease. They don't want to transfuse unless it's 8 or less, or they have symptoms. Acute coronary syndrome. It's not recommended just as a routine treatment for after heart attack. Basically, what you will see, other than ICU or post-operative, basically they will use it by their signs and symptoms and hemoglobin level. Typically, what you will see is that the hemoglobin has to be 8 or less, 7 or less in ICU before they will transfuse. Okay, again, think of transfusion as a transplant. It's not without risk. Okay? Now, why do you think ICU patients are sort of singled out? They're sicker. They may have more chronic diseases. And what else do you see? Any of you work in ICU? How many tubes of blood do you send on those ICU patients a day? Okay. One of the major reasons that you see in the ICU that they need transfusions is because of phlebotomy. One of the things that I used to see when I worked neuro, we shared a unit with bone marrow transplant. They would send 20 or more vials of blood down to be tested every day. Of those 20 vials of blood, each of them had 5 to 7 milliliters in it. Okay? So 20 times 7 is almost a half a unit of blood, right? Typically what you would see is they check blood every morning, transfuse at night. One of the major reasons that you see for blood loss and falling H&H in your ICU patients, other than their disease process, is drawing blood and sending it off for labs. So think about that. Especially if you can add on. A lot of blood testing you can add on. If you can add on to another vial that's been sent, instead of sending another vial, that's a much better way to do it than have to draw another blood. Not to mention you have to go in and actually draw the blood yourself. Okay? Now, Avo Blood Compatibility. Basically, the universal donor is who? Type O. So if you've got type O blood and you've ever donated before, you will get monthly calls. So say, we need your money. Basically, just sort of look over this. Remember, O blood is sort of the universal donor. One of the things that you need to remember is that you have to test for not only blood type, but you test whenever you send a type and cross-match. You check for antibodies as well as the RH factor. Okay, if you have a patient that has RH positive blood, people who have RH positive blood can receive a transfusion from an RH negative donor. But an RH negative person should not receive RH positive blood. Okay? One other thing you need to remember also when you're talking about blood transfusion, remember we transfuse the blood and then you check to see what it did to the H&H. Typically what you will see is 1 unit of packed red cells will raise the hemoglobin level about 1 to 2 points. Okay? Raises the hematocrit by about 3%. Alright, red blood cells. They come in 250 milliliter bags. They can be stored up to 42 days. And they have a shelf life of about 6 weeks if they're kept in the blood bank. Basically what you're going to see is that the majority of patients don't need to have them irradiated. But patients that have received multiple blood transfusions may develop something that we call graft versus host disease. And they may have to have irradiated blood cells. Those irradiated cells will last for about 28 days. So it shortens the half-life. Okay? A couple of things you need to remember about red cells is they're not cheap. Cost between $500 and $1,500 a unit. depending on what all you had to do to them. The irradiated ones are the 1500. Basically, what you're going to see is that when you're talking about neonates or kids, typically they're going to get a dose of 15 to 20 milliliters per kilogram of dose. Now, if I am giving 250 cc's of red blood cells, I am going to be extremely careful about giving this 250 cc's to my little old lady with congestive heart failure, right? Okay. How long can that blood hang? 4 hours. 4 hours. Okay. But what if I have heart failure so severe that I couldn't tolerate 250 cc's in 4 hours? What would I do? Well, I could either give them half of the unit and waste half of the blood, or I can ask the blood bank to split it. And that's what you often do. Now, try not to waste the blood. I mean, it's extremely expensive. Plus, it's short supply. So, if you have someone that cannot tolerate that blood volume, then have them to split the unit. Alright. Basically, what you're going to see is that those transfused cells have a half-life of about 30 days, as opposed to the 120. So, hopefully, what you're going to see is that their H&H is going to increase. Now, platelet transfusions usually are indicated if they have a platelet count lower than 20,000. Because the chance of bleeding is significant whenever it gets below 20,000. You also will see them transfuse platelets with people with thrombocytopenia who are actively bleeding, or someone with ITP or TTP or whatever are scheduled for an invasive procedure. Okay, typically what you will see though is that they're scheduled for that invasive procedure. They give the platelets immediately prior to the procedure and during the procedure and after the procedure. Okay, because remember, if it's one of those autoimmune processes that's destroying platelets, you can't tank them up a week before because those platelets will have already been destroyed. Platelet transfusions are about 200 to 300 milliliter bags. They're fairly fragile. They will break, not the bag, but the platelets. So what you're going to see is that you handle them gently. With platelets, you don't use a standard blood transfusion line because the platelets adhere in that filter, and what you will see is that longer tubing, basically the platelets stick to the tubing. Okay? So what you're going to want to do is that typically when you prime that tubing, probably the first 50 cc's that you infuse will have no platelets in it because they're stuck to the plastic tubing. So you want to use a short set with no filter for platelets. And typically what you'll find is that when you pick them up from the blood bank, they will give you the tubing for them. This is what they look like. FFP, or fresh frozen plasma. Basically what you're going to see is this is the fluid that contains the clotting factors, the electrolytes, and the proteins, including the albumin. Plasma has to be Avo compatible. And typically you infuse it rapidly over 30 to 90 minutes, 60 minutes. FFP basically are units are about 250 mils. What you will find is that they will freeze FFP and it has to be used, I think it's within 24 hours after thawing. Once it's frozen, though, it can be stored up to a year. Now, what you have to be careful about is that sometimes what you'll find is that FFP is what we call pooled donors, meaning that FFP may come, the plasma may come, but 4 to 6 donors make up 1 unit. What you can find is that a lot of patients with cancer, or if they've had previous reactions, they don't use the pooled units. They will use plasma from a dedicated donor. Okay, so that sometimes what will happen is that cancer patient goes in, requires the FFP, they may call their dedicated donor, we need more plasma. Okay? Remember, with plasma, they are not taking the red blood cells and all of that out. They're just running it and they're just collecting plasma. And yes, you can sell your plasma. There's a donation center in Charlotte. Not really sure what the going rate for it is now.
Like $75.
Yeah, I think it's like $40 to $60.
I know 10 years ago, whenever I was in my first year of college, it was $30 for the first time, I think 40 for the second, and it was 15, 15, 15, 15, and then it was like 40 for the last. And they gave you a free pizza dinner.
Yeah, they feed well. I've had friends that finance their entire college costs between plasma and semen collections. But one of the things that's really come out in the past couple of years, though, with plasma, typically the American Red Cross basically has decided that they're going to use plasma transfusions from men only for FFP donations or platelet donations. Basically, the reason is that women that have been pregnant are emerging as a chief culprit for a reaction that we call trolley, transfusion-related acute lung injury. Okay, it's sort of like an acute acute respiratory failure, and it usually occurs after they have been transfused with either plasma, sometimes platelets, but most of the time it's plasma that they've gotten. So typically what you'll find is that the majority of the time, if you get a plasma, it's male, okay, because of the RH factors and all that other stuff, the antibodies that we develop. Trolley, as I mentioned, it's a non-cardiogenic pulmonary edema. It occurs within 6 hours of transfusion of any blood. Typically what you see is hypoxemia, cough, dyspnea, very copious secretion, pulmonary edema on chest x-ray, fever, hypotension, and low O2 sat. What does that sound like, guys? It sounds like congestive heart failure, but it's not. Like, it's non-cardiac, okay? Basically what happens is this is like acute respiratory failure. Treatment supportive. Usually what you'll see is that they will take them to the unit, intubate, ventilate for a couple of days, and then they completely recover. But it's just a reaction that occurs after that transfusion. Now, chiroprecipitate is given for your patients with hemophilia basically with deficits of clotting factors 8 and that should be 9 instead of 13. Von Willebrand's factor and fibrinogen. You may also hear Christmas disease. It's one of those absence of, I think it's clotting factor 11. But with chiroprecipitate, it's usually, it can be infused via IV, but most of the time it's given IV push within 3 minutes. As I said, it has to be given on a regular basis, and the majority of times you will find that patients that need this infusion will do it themselves. Typically with von Willebrand's or Christmas disease, they will get an infusion of whatever factor it might be prior to any invasive procedure. They typically don't need routine. But if you have hemophilia, you will get a weekly dose or more frequent dose of those clotting factors. Some of the cultural considerations. What do we know about Jehovah's Witnesses? Okay? And I'm going to clarify that. They will not knowingly take blood. Gosh. Or they may take it as long as someone else in the church does not know about it. So typically what you will find is that if you have been asked to approach the Jehovah's Witnesses with a physician about talking about blood transfusion or blood products, you do it in a private manner. You don't do it in front of other family members. You don't do it in front of other members of the church. Because I have had some patients to take it as long as it was done in the middle of the night and no one else was there. However, the majority do refuse. So what types of things can we do if someone needs an infusion of red cells? Apigen or Procrit? Extra fluids. Basically, typically, I've seen most Jehovah's Witnesses that I've cared for will take the Apigen or the Procrit. Because what it does is it stimulates a natural process. Okay? And the teachings of the church do not prohibit it. Okay? Alright. Let's take a break and then we'll talk about these types of transfusion reactions. Now, if I had to focus my studying, this would be what I would focus on. Okay? The other is sort of background information building you up to these next slides. Transfusion reactions and recognition of them are one of the most important things that we're going to do as nurses. Number one priority is make sure the right patient gets the right blood. Number two is going to be recognition of any of these reactions. So let's go through these and talk about them. The one that you do not want to see is this one, hemolytic transfusion reaction. It's caused by incompatible blood being transfused into a patient. Basically what you will see with hemolytic reaction, fever, chills, flushing of the skin. They feel like they are dying. One thing that you always want to listen to is if your patient says, I feel like I am dying. You better perk both ears up because more than likely they are. Okay? That impending doom feeling. Chest pain, low back pain, headache, tachycardia, tachypnea, and hypotension. Fever, chills, flushing, impending doom, chest pain, low back pain, headache, tachycardia and tachypnea, and hypotension. Now, what you will see with a hemolytic transfusion reaction is it can be acute or it can be delayed. Typically, what you will see is that this usually happens acutely after the reaction. This is one of the reasons why you run this blood slowly in that first 15 to 20 to 30 minutes to see what kind of reaction that they're going to get. Because I would much rather deal with the first 20 mils out of that blood or the first 30 mils out of that blood than that whole unit with this transfusion reaction. Okay? Now, delayed hemolytic reaction usually occurs 1 to 4 weeks after the transfusion reaction. Often what you will see with this delayed reaction is not these signs and symptoms that you see with the acute, but what you typically see is an HH that tends to fall. Okay? I'm going to give you a clue. I don't care what kind of transfusion reaction that you might think that you've got. Number one rule is stop the transfusion. Okay? You are going to make sure that you keep that vein open using normal saline. And then what may occur is this patient goes to the unit where they treat it with vasopressors to combat that hypotension and treat the DIC that's going to occur. Okay? So acute hemolytic, fever, chills, flushing, chest pain, low back pain, hypotension. Allergic transfusion reactions. There are 2 degrees of allergy here, guys. Allergic, urticaria, itching, headache, and mild wheezing. That's sort of like you see after a mosquito bite. It's a mild reaction. You get the urticaria, itching, headache, mild wheezing. The allergic reaction you don't want to see is anaphylaxis. Okay? Dyspnea, hypotension, bronchospasm. Their airway closes off. You see respiratory arrest and shock. Typically, what you're going to see is that this can occur up to 24 hours post-transfusion. The majority of your times when you have someone that has either allergic or anaphylactic reaction, they've been given multiple blood transfusions and they're starting to develop other antibodies that they haven't been cross-matched for. Okay? One of the ways that they will treat that is they wash their red cells and basically remove the antibodies from those red cells. That's why the cost of that blood gets up to $1,500. Again, if you think someone is having an allergic reaction while they're being administered the blood, stop the transfusion. Keep the IV open with normal saline. Typically what you're going to see is these people will get corticosteroids and they're going to get antihistamines like Benadryl, cortisone, or Cyamedrol to help combat that allergic reaction. Now, if they have an allergic reaction and they still need blood, that physician is going to think long and hard before giving it to them again, okay? But typically what they will do is they will pre-treat with antihistamines and the corticosteroids and give them those washed red cells. Brings up an important point. If you have someone that has been typed and cross-matched and has received 4 units of blood, they probably should be typed and cross-matched again. Even if that first type and cross-match is good, up to 72 hours. Because every time that person gets blood, they get exposed to another set of antibodies. Okay? Febrile transfusion reactions are probably the one that you're going to see most often. They occur in about every 200 to 300 transfusions. Basically, they occur at the end of the transfusion or with 1 hour of completion. Okay? Basically, your temp just goes up. 1 degree Celsius or 2 degrees Fahrenheit without any other causes. It's more common with platelet transfusions. Again, if you suspect a transfusion reaction, stop the transfusion. Antipyretics, like some Tylenol or ibuprofen. Antihistamines, like diphenhydramine or Benadryl. Corticosteroids, like Cyamedrol or methylprednisolone, may be administered, and the patient's body temperature lowered. Typically, if you've had a patient that has had a febrile transfusion reaction previously, they will do leukocyte-reduced products. And a lot of times what you will see, again, they will pre-treat with Tylenol for these patients. This is one we don't ever want to see. It's because of bacterial contamination in blood products. Usually what you will see is a very rapid onset of signs and symptoms that include tachycardia, hypotension, fever, chills, and shock. Okay? One of the things that you should observe that blood for is bubbles. Bubbles in blood are a bad sign, because that may indicate bacterial contamination. One of the reasons why it's kept in the blood bank until it's ready to transfuse. Because not every little refrigerator has the right temperature setting. But the blood bank refrigerators are set at the appropriate temperature to help decrease bacterial transfusion. Now, say for example, I suspect a bacterial transfusion reaction. What am I going to do with that blood? Stop the transfusion. Infuse normal saline, and what else am I going to do? I'm taking that blood and culturing it. Okay? The whole bag, the whole tubing, everything goes in a biohazard bag with that patient's label on it so it can be cultured. Okay? Circulatory overload, transfusion-associated circulatory overload. TACO is due to rapid infusion, typically is caused whenever you have multiple infusions back to back, or you've infused whole blood. Remember, whole blood has plasma as well as the red cells in it. It often happens to your older clients, especially with those with compromised cardiovascular status. Okay? They're at risk for heart failure. They're at risk for circulatory overload. Signs and symptoms that we see are hypertension, bounding pulses, and by bounding pulses, what do I mean? Are they 1 plus, 2 plus, or 3 plus, 4 plus? Okay. You may also see JVD, dyspnea, restlessness, confusion, and pulmonary edema. What does that sound like? Congestive heart failure, because that's exactly what it is. Transfusion-associated circulatory overload. Again, what we're going to do to prevent this is run the blood at an appropriate rate for your patient's condition. Split the unit if you have to. You don't want them to have that circulatory overload. Alright, this is not a type of blood transfusion reaction, but just as an FYI. Autologous blood transfusion. Don't do this as much anymore. Used to be, if you had someone that was going hip replacement or bypass or whatever, 2 or 3 months before the surgery, they would go and bank their own blood. It's preoperative blood donation. What they do is they give them high iron doses and soup up their blood and then take it off and save it so that they can retransfuse them if they need it. What we see nowadays is more intraoperative blood salvage. Dayball is a type of auto-transfusion device. Basically, it filters out clots, bone fragments, whatever other junk that's in there, and you can retransfuse their blood that was salvaged during the surgery as long as it's retransfused within 6 hours. And typically they don't transfuse it unless it's more than 500 cc's. But a lot of your orthopedic surgeries may have that much blood loss. So they would do a salvage and retransfuse. Now, a couple of things you need to remember about responsibilities for pre-transfusion. It requires a physician's order. They have to have a type and cross match, typically within 72 hours of the transfusion. And I'm going to tell you, if you got an order for 2 units of blood and you start that transfusion at 70 hours, they're going to require another type and cross match before you give that second unit. Okay? Consent. It is a informed consent. Again, it is a procedure that's not without risk. Patient education. What do you think some of the patient education would be that I want to tell them? You need to let me know if you start feeling funny or having some problems breathing. You know, sometimes you want to teach enough, but you don't want to put signs and symptoms in their head. Okay? How are you feeling? Those types of things. Pre-transfusion assessment. This is even before I've gone to get the blood. I want a set of vital signs. and I want a temperature. Because if this patient already has a temp, I'm calling my doc and saying, hey, Mr. So-and-so has a 101. I have not transfused the blood yet. Do you want me to go ahead now or do you want me to wait? Because if I've already gone to get the blood and find that, oh, he's got a temperature, then I'm SOL. I either have to take the blood back down to the blood bank, check it in, and they look at you like, didn't you do this before you came down here? Or I'm hoping that I can get his temperature down in 15 minutes. Because that blood has to be transfused in that patient, including all of the checks that I've got to do within 30 minutes of checking out from that blood bank. It's not one of the things that you go on your way to lunch to get it. No. I want the correct tubing and the correct IV site. What size blood needle do I want? 18. 20 minimum, 18, 16, 14 are preferred. Okay? If I got a PICC line, great. I'm going to transfuse it via the bloodline. But you want a large bore. One of the things that you'll see is that if you try to transfuse those red cells in anything less than a 20, they lyse. Okay? It's too small for them to go through. Correct tubing. Remember I said something about filters? Okay? Red cells are filtered. Platelets are not. So this is a Y site. This would be what I would use with the longer tubing for my red blood cells. This would be what I would use with my platelets. Now, one of the things that you will see is that blood will run on a pump, and it should be. That will help prevent that transfusion-associated circulatory overload. Now I'm going to obtain my blood from the blood bank after I've got all my S together. Okay? One of the things that they're starting to do is that, especially at CMC Northeast, not sure about Rowan, but I'm sure that once they get Epic up and running, that this will happens as well. One of the checks will be that you will scan the barcode on the blood. In addition to going by your checklist for your checkoff sheet. It has to be scanned into the system. Okay? So that will be one of the things that you'll look at. 2 people check. One checks the patient's blood band. One checks the blood. One checks the checklist. Okay? So you blood band, and blood. The other person has the checklist. Okay? Responsibilities. Verification of patient identification is a priority. Correct blood to the correct patient at the correct time. We want those 5 or 6 writes to be right on this blood. Vital signs. How often am I checking vital signs? Every 15 minutes. Remember, I'm starting that blood very slowly to begin with. And for that first 15 minutes, as the RN responsible for that transfusion, I'm not at the desk charting. I'm in that room with that patient. Because what I want to do is to be able to lay eyes on that patient and observe for any type of reaction that they're going to have. Okay? Any severe reaction usually occurs within the first 50 mils of the blood. Normal saline only. The only thing you can transfuse blood with is normal saline. Blood products, as a rule, normal saline. The other thing that I don't want is I'm not giving any medication or giving anything else via that line that I'm running blood with. Blood only, normal saline only. Okay? If you suspect any reaction, stop the transfusion and run that normal saline. You want to keep that IV line open so you don't collapse that vein, because it may be what you're going to give your ACLS drugs through. Okay? Questions about blood or blood transfusion?